There are many topics that we need to cover for the respiratory system, and the one that we're going to talk about today is actually how we ventilate. How do we actually get air into and out of our lungs? And this is hugely review of anatomy. We need to talk about the lungs and their anatomy and the diaphragm and the pleural cavities, and all of that should be review. Then I will tell you about the muscles involved for quiet inhalation versus forced inhalation, and what muscle contraction is necessary for exhalation. Sometimes muscle contraction is necessary and sometimes it's not. So pay attention to quiet breathing versus forced breathing because the musculature is different. It might surprise you that many times in anatomy, a professor will use an analogy that the lungs are like a balloon. They inflate and they deflate. And they are elastic structures, and they do inflate and they do deflate, and they do look a lot like a balloon. However, how do you inflate a balloon? You take a deep breath in, you apply pressure, that pressure gradient then forces an air flow, and then you cause a volume change in the balloon. That is not how we inflate our lungs. That would be weird if we went through life saying, "Oh, Elizabeth, give me one." Okay, now it's your turn. We would not, if we had to inflate our lungs the way we inflate a balloon, that's called positive pressure breathing, we would have to have something over our mouth pushing the air into our lungs. That is not how we breathe. And by the time I'm finished with just this lecture and then the next lecture, I think you'll be surprised how our body takes the most challenging way to ventilate. Not the easiest way. We use negative pressure breathing. So in order to appreciate pressure changes leading to volume changes and the reverse, I need to at least remind you of the anatomy of the lungs and the musculature involved with the respiratory system. We are going to quickly review the functions of the respiratory system. Sorry. Usually I have an audio bite, and I thought I heard it, and it usually creeps students out. It sounds like Darth Vader breathing in the distance. Our respiratory system is not just for ventilation. We also use parts of our respiratory system for vocalization. Arguably one of the best movies, just for fun, a fun movie where you don't have to overthink, is Dumb and Dumber. Arguably. And there is a part in that movie where Jim Carrey goes off script, and they had the cameras rolling, and of course it made the editor's cut. And it's the part where they had the bad guy who thinks they stole the money, if you remember this movie. And the bad guy sitting in the middle of the two, Jim Carrey and Jeff Daniels. And Jim Carrey turns to the bad guy and says, "Do you want to hear the most annoying sound the human body can make?" or something like that. And the character, he didn't break character. He was just like, okay. And Jim Carrey goes, "Ah!" And I thought that is a perfect example of us using our respiratory system for vocalization. We resonate sounds in our nasal cavity and in our sinuses. It's also a place where we have a lot of macrophages that are phagocytizing about 1 million particles that we breathe in on a daily basis and getting rid of those pathogens. So we're actually fighting a lot of pathogens. You're in a fog of pathogens right now all around you. There's bacteria, there's viruses, and you're breathing that in, and your macrophages and your lung tissue beds are fighting that off. It is a place for insensible water loss. Evaporation of water comes through our lung mucous membranes. We also lose heat through our lungs as well. Breathing does enhance our venous return. When you breathe in, it helps pull blood up from the abdominal cavity, from the inferior vena cava, and when you exhale, it pretty much shoves the blood into the atria. And then also, we already know about the RAA mechanism, and how the pulmonary capillary beds are part of that pathway, creating angiotensin II with the ACE found in the pulmonary capillary beds. So tonight's focus is to look at how we ventilate, what muscles are required for breathing in and breathing out. We will then move on with that, and you will learn about the work of breathing. Most of us do not think of breathing as work. Are you working at breathing right now? Do you have to think about breathing to breathe? Have you ever been so sick you had to think about breathing to breathe? And that's a scary feeling, isn't it? You will learn this week and next week, we will be doing some labs that focus on the work of breathing. Believe it or not, your patient will posture themselves, position themselves, and if you just look at them, you will be able to figure out where their work of breathing is. For us, normal, healthy individuals, our work of breathing is when we inhale, and I'll explain why in just a moment. But if you have certain disease states where breathing in is even more work, you're going to use a lot of ATP. And you're going to posture yourself so that I can see, oh, you're using more ATP for that inhalation. Exhalation is supposed to be passive. Under normal quiet breathing, no muscle contraction is necessary to exhale. You simply relax muscle groups. But if your exhale is now worked, forced, you're going to recruit muscles to help with the exhalation, and you will posture yourself differently. For example, how would you look to me? What would you do if you were struggling to breathe in? Okay, good. And I'm seeing some of you in your chairs going like this. You're straightening up in the chair. How would you look to me if you were struggling to exhale? What would you look like? So I'm seeing Juliana starting to slouch. She's taking the tripod position. We'll talk about that posturing. It's a dead ringer for which part of breathing is their struggle. And there are two categories for struggling to breathe. It's either inhalation or exhalation. But in the medical field, we give them different terms. We say obstructive versus restrictive. Restrictive breathing is an issue with inhalation. That's your problem. You can't inhale. Obstructive breathing is a problem with exhale and gas exchange. And again, you will have an official lecture on the work of breathing where we will go through those two categories, what your patient will look like, and how we can assess clinically which part of breathing is their problem. Once we're done with learning about ventilation and the work of breathing, the rest of this semester we're focused on gas exchange. It's cute, it's darling. When you took anatomy, you were told that we have gas exchange across the mucosa of the respiratory system. And you were told oxygen diffuses into your blood and CO2 diffuses out of your blood. Well, that's true. However, we know about Fick's law for the rate of diffusion. And there have to be certain criteria. You have to have permeability. You have to have a gradient. We need to talk about what kind of gradient. You need to have good surface area for this gas exchange. There's a lot of things you need for this diffusion to occur. And some people have a problem with this gas exchange. That would be the obstructive category that you're going to learn about. Then, once you get the oxygen into your blood, you've got to transport it. We got to talk about the ways you transport oxygen. You transport oxygen two different ways. We also need to talk about ways you transport CO2 in your blood. You transport CO2 6 different ways. So although we don't have very many PowerPoints left, very many lectures to go through, the last one is by far the hardest one of the semester. There are a lot of gas laws I have to get you through. In order for you to understand those, I have to review the anatomy of the lungs. In your lungs, You have the surface area approximately of a tennis court. And where are your lungs, by the way? And how big are they? Well, your diaphragm, when it's relaxed, domes up to about the height of your nipples, your natural nipple line. And on well-inflated lungs, the apex of the lung can actually clear your clavicle. So it's not that much if you think about it. We oftentimes think our lungs are like this big. No, they're tiny little things if you think about it. But they have height. And they have zones related to them. And that adds to the complexity of our lectures for the remainder of the semester. But you have a surface area of a tennis court in this tiny little space. That means under normal healthy conditions, that surface area is enough to allow for rapid diffusion of your gases. CO2 coming out, oxygen going in. We also need to review your respiratory membrane. Your respiratory membrane consists of the simple epithelium of the alveoli. You have about 1 million alveoli in each lung. Then we have a fused basement membrane, and then you have the pulmonary capillary beds. Okay, it's the same kind of setup. It's the same anatomy as your filtration membrane. Epithelium, fused basement membrane, endothelium. It's the thinnest possible distance. And that distance is 0.2 microns. That's the thinnest possible distance to allow the most rapid gas exchange. What do you think is going to happen if that distance increases? You're not going to have rapid gas exchange. You might actually have blood return to the left atrium not as well oxygenated as it needs to be. That's a problem. So our respiratory tract, and no mouth breathers. No mouth breathers. We're going to start with the nose. Your external nares, you're going to go through your nasal cavity, posterior nasal apertures. You're going to pass your nasal turbines, your choani. You're going to go into your nasopharynx, pass through your oropharynx to your laryngopharynx to the larynx. Now you're in the trachea. Trachea have these cartilaginous C-rings, and that's to keep the trachea open in between breaths so it doesn't collapse. Being a mucous membrane, if your trachea collapsed, you would have a hard time peeling it back open on your next breath. So the tracheal C-rings keep it patent or open. Then you have a right and left primary bronchi, turns into secondary bronchi, tertiary bronchi, then to smaller and smaller bronchioles. You can see as we get into smaller and smaller structures, we get more of them. This is us, or this is the anatomy, showing us where we're getting, as we get smaller, greater surface area for gas exchange. We can anatomically and physiologically separate our respiratory tract, and even clinically. You've heard of, oh, you have an upper respiratory tract infection or a lower respiratory tract infection. Well, in physiology, we're worried about conducting zone and respiratory zone. Conducting zones are, or a conducting zone, includes structures that you have too few of them, they're too big and too thick for gas exchange. For example, trachea. You have one trachea, it's very thick, has these cartilaginous C-rings. You do not have gas exchange. The bronchi, still too big, too few of them, too thick, can't have good gas exchange. It's not until we get to the terminal bronchioles that that's the end of the conducting zone. Terminal bronchioles, that's the end. It's not until you get to the respiratory bronchioles, to the alveolar sacs and the alveoli, that you now have small enough structures, abundancy of them, with a distance for gas exchange that will allow the gas exchange to happen in 1/4 of a second. 1/4 of a second. The problem is, as you get to these smaller structures, What do you notice about the cartilage? It disappears. And these smaller structures are still aligned with mucous membranes. Wetness. And water has this property called cohesive property. And in between breaths, those smaller structures that don't have cartilage to keep them open, to give them rigidity, they can collapse. And that's part of your work of breathing, trying to get them to open up again. So keep that in mind, these smaller structures with no support that are prone to collapse. And then you have to work even harder to peel them open. And I'll give you an analogy of that when I get to a certain point in the lecture. So ventilation includes two parts, your inhalation, also called inspiration, and your exhalation, also known as expiration. When we say someone has expired, it means they have taken their last breath, right? They have exhaled for the last time. We need to understand the musculature involved for normal, quiet inhalation, forced inhalation, normal, quiet exhalation, and forced exhalation. And there are test questions on which muscles are required for each of these processes. And in order for me to explain to you how we get air in and out of our lungs and the musculature required, I need to introduce a gas law, Boyle's law, part of the ideal gas law. And I also need to review the anatomy of the contact between your chest wall and the surface of the lung. So let's start with our gas law, PIV-NERT, pressure times volume, it's P and V, equals N, which stands for the number of moles, R stands for an ideal gas constant, and T stands for temperature. Well, we are homeotherms, so we don't need to worry about temperature. And R is a constant, and constants means they don't change, so we don't need to worry about that. Number of moles, well, the number of moles, the amount of air we're breathing, does not really change from moment to moment under healthy conditions. It's not like we're going up to Mount Everest in 2.2 seconds and then back down again. So we can reduce this gas law to two parts that can change and do change when we ventilate, pressure and volume. And Boyle's law says that pressure and volumes are going to be inversely related. Now, my boys, when they were in middle school, they had to take a science class, and they learned about weather systems. And they learned about pressure changes leading to winds and changes of the weather. And in these chapters for their weather systems, they actually introduced Boyle's law, and the pressure and volume are inversely related. And that air flows from high pressure to low. Okay, so they said, Mommy, we don't understand. Air flows from high pressure to low. What do you mean? So I took them upstairs. I have a fan in my bedroom, and I turned on the fan. It's a little table fan. Turned on the fan. I said, stand right here in front of it. And I put their face right in front of the fan, and it was blowing the air onto them. I said, do you feel the air? They said, yes, it feels strong on my face. I said, that's high pressure. Now go way over there. Do you feel the air? And they said, a little bit. I said, that's low pressure. The air is going from the fan, high pressure, to low. That's how air is flowing, high pressure to low. And that's not new to you. You know that that's how fluid moves, right? Blood, high pressure to low pressure. Air is the same way. And they said, Mom, but we don't understand this pressure and volume is inversely related. I said, okay, let's go to Mommy's office. My office is about the size, 2 arms length in width, maybe 4 in length. It's small. It would be the size of your 2 tables together. And I've got 2 desks. It's the smallest little office. It's supposed to be a bedroom. Maybe if you were Harry Potter sleeping under the closet, but it's small. So I bring him into the office and I close the door and I said, we're gas molecules. We're vibrating. We've got energy in our bones. We're moving. We're shaking. And the boys are like, yeah, this is fun. I said, wait, it gets better. We're in a container. We're in the office. We want out of this. And they're like, we want out? We want out. Let's strike. And they said, what do you mean strike? I said, we're moving. And so we started hitting the walls and each other and the door and back and forth. It was all very fun, especially for two little boys. Anything physical. It's fun. And I said, we are in a small container. We had a lot of strikes on the wall, on each other. Did you feel that? Did you feel that pressure when I body slammed you? Yes. So I said, okay, now let's go into mommy's room. So I took him into my bedroom, which is obscene. It's a bonus room. It's not supposed to be used as a bedroom. It's the size of this classroom. I have a bed, 2 side tables, 2 dressers. That's it. And the boys play indoor soccer in my room. I don't know why. We have a park right outside the gate. But in the park, when you kick a ball, you have to go chase it. In the house, you can bank the soccer ball and you don't have to go chase it too hard. You don't want to know how many glass mirror doors we've gone through. Those don't like a soccer ball banked off of them. So I closed the door, big room. I said, we're molecules, we're gas molecules, we're movers, we're shakers, we're moving, and we strike, we want out. It was very boring. It was very boring because this is what it looked like. Not a lot of strikes. The boys were very bored. I said, bigger volume. Less opportunity for us to strike and feel the pressure against the wall or each other. And that, I said to the boys, means that pressure and volume are inversely related. If you are a gas molecule trapped in a container, the smaller the container, the more you're striking the walls and each other. And every strike, it's pressure on that container. I want out. I want out. I want out. Bigger container, less strikes, fewer strikes. Get the idea? Okay. So we have Ohm's Law from Unit 2 right back. It's actually also from Unit 3. Flow equals, we need some sort of change in we need a driving force. In this case, it's going to be change in pressure. Change in pressure. Atmospheric pressure, gas pressures, not fluid pressures like we learned in Unit 3. Not voltage gradients like we learned in Unit 2. And resistance is in the denominator again. Now in Unit 2, resistance came in the form of size of the axon. Is the axon myelinated or not? Are gated channels open or not? In Unit 3, resistance came in the form of our tunica media, the arterioles. Is it constricted or not? In Unit 4, resistance comes in the form, for the respiratory system, in bronchial dilation. Or is it constricted? It's the same concept, but now we're in the lungs. We need a driving force divided by resistance. The driving force is pressure. That's the same as Unit 3, but it's a different kind of pressure. We're talking about air pressures. And there are 4 different pressures I need to tell you about in order to learn about ventilation. Some of these won't be new to you. Some of them will. Some are more complicated than others. Some actually are directly involved for ventilation and others not so much. In order for us to get pressure differences, to get airflow, we actually have to create a volume change in our lungs first. That's crazy. We have to create a volume change in our lungs first. That will then second lead to the pressure difference. That will then third lead to flow of the air. When we breathe in, what happens to our chest? Breathe in for me. Look how big you're getting. Your chest is expanding. That's the volume change. Then you're creating a pressure change according to Boyle's law. Then you can have a flow according to Ohm's law. The problem is that the lungs are not muscular structures. They are like a balloon. Can you look at a balloon, talk to it, and say, I want you to change your volume? Change your volume. Balloon can't do that. It is made of elastic fibers like our lungs. Our lungs are not muscular. They cannot change their volume on their own, which means we must have a very unique anatomy, a functional contact, an anatomical contact between the chest and the lung. And if you disrupt that contact, then the lungs will go just like a balloon. Do you know what that's called in the clinical setting when your lungs just go? Okay, that's the fancy schmancy term. Okay, so collapsed lung. Pneumothorax is a way to get that, and the more clinical is atelectasis. So collapsed lung, atelectasis. Pneumothorax is a way to get an atelectasis or collapsed lung. That means you no longer have the chest wall and the lungs tethered together. The chest wall has the musculature that can contract to cause volume changes. The lungs have to follow. When you inhale, when the chest wall expands, the lungs are stretched open. We have now created a volume change that will lead to a pressure change, and then we will get airflow. That's what we have to talk about this week and next week. So is everyone okay with pressure and volume being inversely related? If the lung volume is bigger, then the pressure of the air in your lungs is lower. If the lungs are small in volume, then the air in your lungs now is striking with greater pressure, just like the analogy with me and the boys. Are you okay? Okay. Once you have a pressure difference, then you get air flow. And when we breathe in and out, we don't need much of a pressure difference to get 500 milliliters of air to flow in and out of our lungs. That's the size of this bottle. With every breath you're taking at rest right now, you're getting this much air in and out of your lungs. And the pressure gradient you are creating is about a 1 to 2 millimeters of mercury worth of pressure gradient to get that much air in and out of your lungs. It's not a lot. It's not a lot. Which is why most of you, when I said, how many of you think of breathing as work? How many of you are struggling right now to breathe? Most of you went, no, not really. And it's because we don't have to create much of a pressure gradient to get this much air in and out of our lungs. It's not a lot of work. So let's talk about normal inspiration. The muscles for inspiration that you require contraction from are the diaphragm and the external intercostals. The external intercostals originate from an upper rib, they insert on a lower rib, and when they contract, they will cause changes anteriorly and posteriorly in your thoracic cage. They expand anterior and posterior. They will also help expand your rib cage laterally. So we've got two axes now. The diaphragm is a domed-shaped muscle, and when it contracts, it flattens out. And when that happens, your thoracic cavity is now expanding superiorly and inferiorly. So we get X, Y, and Z axes for expansion. This way, and this way. So when those muscles contract, they create the volume change. The lungs must be compliant and stretch along. Well, what makes the lungs stretch along with your chest wall and the diaphragm? Pleural membranes in the pleural cavity filled with fluid. We'll review that in just a moment. So in order to inhale, you require consumption of ATP. You require this ATP for muscle contraction. We learned that in Unit 2. This is an active process because you are using ATP. If you want to have forced inspiration, you're at the gym, you're on the treadmill, you need the following muscles. You still need the diaphragm to contract. You still need the external intercostals to contract. But now you're going to have even more muscles helping to expand your chest. You're going to use your sternocleidomastoid. That helps elevate the clavicle, which is still muscularly connected to your ribs, so it kind of pulls. You can use your scalenes. You can use your erector spinae muscles. So sternocleidomastoid, scalenes, erector spinae, serratus anterior. Remember that is a muscle that originates from your scapulae and inserts on the upper 8 ribs, and when it contracts, it helps expand your rib cage. So you would need all these muscles plus the 2 for normal inspiration. What would you need for quiet expiration? No muscles. None. You just relax the diaphragm and external intercostals. You would not need any ATP for normal quiet exhale. That would not be part of work for your breathing right now. All of you, normal quiet exhale. So you heard me say that when the chest wall expands, the lungs have to be compliant. They stretch with it. What makes them stretch or be compliant? What pulls them out with the chest wall? We have these pleural membranes. We have a parietal pleural membrane and a visceral pleural membrane. Parietal shown here in the bluish purple, and visceral shown here in kind of the fuchsia color. In between is a potential slit-like space. It is not filled with air. It is filled with fluid, pleural fluid. Now, pleural fluid is not water, and it's not blood, but it's derived from blood, and it does have viscosity, it has stickiness to it. It also is a lubricant, because when your lungs inflate and deflate, we don't want them to rub on the chest wall. This would create a frictional rub, and it would be very painful. You would feel that, and you'd be aware of that. Have any of you ever had pleurisy? Weird to think, with every inhale, you feel this rub. Now think of sandpaper rubbing on your skin all day long. What would your skin feel like at the end of the day? Raw? Sore? You'd want that to stop? Now imagine that happening with your lungs scraping on your chest wall. How do you get that to stop? You have to breathe. It's extremely painful. That pleural fluid acts as a lubricant so you don't get the frictional rub. That pleural fluid also ensures that the surface of the lung has to follow along with the chest when we expand, when we inflate. But what is it about pleural fluid that makes the surface of the lung go with the chest wall? How many of you wear contact lenses? Not enough. How many of you know what a contact lens is? There we go. It is a cup-shaped structure that fits on your cornea, which is also curved. And this cup-shaped structure is made out of a special kind of plastic. Now, for those of you who don't wear contact lenses, please understand that the surface of your eye is watery. I think you know that already. And when you put this plastic cup on the cornea of your eye, it's held in place. For the most part, right, contact lens wearers? For the most part. And it's annoying when it doesn't stay in place, but for the most part it does. And the reason is that the watery surface of our eye, with the water cohesive properties, holds that plastic to the surface of your eye. Now at the end of the day, when we have to take our contact lens off, we have to peel it off the surface of our eye. We have to generate enough pressure to peel it off the surface of our eye, breaking the cohesive bonds of water molecules. Water does not like to be disrupted in that way. If you have water, go ahead and sprinkle some water on the surface of your table. Just a little bit. You can even use the disinfectant if you want. Just a little bit. A little sprinkle. Just a tiny bit. Just pour it on the table. You're going to make a clean spot. Now the tiny little drop, I want you to spread it across the entire surface of the table. I want a uniform, spread it across. Now see, what you're doing is you are rubbing it to the point where it's drying. I said I want it spread. And when you first started that, do it again. Pour a little bit again. And instead of taking your whole hand and smearing it dry, just use the tip of your finger and spread it across the table. What do you see the water doing as you try and do that? Is it spreading or is it balling up? It's balling up, right? It didn't like to be spread. And that's because, and I'll act it out for you. All of those water molecules in the liquid form are faced with air. There's air above the water you poured on your table. Do you agree? Okay, so what you can't see, you got to put on your molecular glasses to see this. I'm going to act it out for you because I've seen it. I have molecular goggles. What you don't know is going on with those water molecules that you just poured on your table is the following. They are all linked together through hydrogen bonds. Water is somewhat polar, right? We say it's dipolar. And those water molecules, they like those hydrogen bonds. And they're like, kumbaya. And they like to link together. And then all of a sudden they see one of their brethren go from a liquid phase to a gaseous phase. And the remaining water molecules go, Johnny, don't go! Don't go! What happened to him? I don't know. Nobody else go! Kumbaya! Just keep swimming! Down! 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 Pull down! Pull down! Don't go! Don't go! Sally! 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 No! We can't lose any more! See, this is what's happening. You can't hear it, but I have special recording. And in chemistry, it was cute. They were like, when you try and measure a liquid in a graduated cylinder, you need to look for the meniscus. Remember that? What was the meniscus? Describe it to me. This part, right? And you read at the bottom of the meniscus. Why didn't you read at the top? It was those water molecules clinging to the glassware Some of them going to the dark side. Some don't go. Swim down! Swim down! Everyone together! And that's why you saw the curvature. Yes? So water has cohesive properties. Water molecules want to stick together. Don't go. The thing is, when you try and take off your contact lens at the end of the day, you have got to disrupt that cohesive property. And it's pretty strong. And so some of us who wear contact lenses at the end of the day, we're like, whew, over our bathroom sink. And we know we have to pull hard enough to disrupt those cling together, but not so hard that we rip off our cornea at the same time. You have to use finesse. And then if we pull hard enough where we get it off the cornea, sometimes we're a little overzealous and we pull off our contact lens, and this cup-shaped structure now turns into a taco. And what you're seeing in the taco is a whole bunch of water molecules going, stick! Don't go! And then we're like, son of a bitch, gotta peel this open, gotta peel it open. And you have to use a lot of force on such a tiny little piece of plastic. And we usually rip it. And we learn, don't we, contact lens wearers? Oh, fight water with water. We don't need to peel it. We just need to squirt some more water, and then it'll just go, oh, we're with our brothers. Just squeeze more water, and then the contact lens goes, oh, like a flower. It's true. Those of you who don't wear contact lenses, these are the trials we have. Now, cohesive property on a contact lens, bad when you're trying to open that taco up. Good when we want the contact lens to stick on the surface of our eye. It's like a suction cup, isn't it? Do you have a suction cup in your house? In your shower, maybe? For your loofah sponge to hang it up on? Your razor? Have you ever put a suction cup on a flat surface, pushed it on, only to see it go, falls off, you pick it up, and you watch it slowly pull away, falls off. What do you do? And it sticks, doesn't it? Cohesive properties. The water molecules inside are like, don't go! Stick together! And you could pretty much hang on that suction cup, right? You have to take then something to break that suction for it to pop off again. It's pretty cool. That's what we have in our pleural cavity. These pleural membranes are making the fluid, the lubricant, but also acts, it's water-based. So now we have the surface of the lung functionally attached to the underside of the chest wall and to the upper side, superior side of the diaphragm. Suction cup. So if the chest wall expands, the lungs get pulled with it. They are not muscular structures, but they are elastic and they can stretch. So when your chest musculature contracts for expansion, the lungs get pulled with it. Volume change. Then with the volume change, we get pressure changes. And that's how we get airflow. So let's go back to our balloon. How do we inflate a balloon? We take a breath in. We apply the pressure. We get flow. Then we get a volume change in our balloon. That is not how we inflate our lungs. Instead, if you want a visual analogy of how we inflate our lungs, do you see my balloon? Do you see it? Here's the stem. Here's the bulbous part. Everyone grab a part of the bulbous part. Grab a part. Just the edge. Everyone pull, everyone pull, everyone pull. Volume change first. Keep pulling. I'll grab the stem. It's inflated. Can you imagine? All of us inflating a balloon by stretching. That's the volume change. Then the air in the balloon, according to Boyle's law, is a lower pressure than the air pressure out here. And the air will now flow because we have a pressure gradient from high pressure to low. I grab the stem, I tie it off, our balloon is inflated. Not one of us had to put our lips to the opening of the balloon. That's how we breathe. Could you imagine? That's how we breathe. It's the most difficult way to inflate a balloon, and that's how we breathe. But it's socially better, don't you agree? Because it'd be awkward. Elizabeth, do me now. Do me. Do me. Okay, now do you. Okay, do me. We would just have a partner all day long, all night long. Be constant CPR back and forth. We'd never get anything done. So that pleural cavity is filled with water. There is a suction, a negative pressure, and this helps the surface of the lung to go and be tightly adherent to the underside of the chest and superior side of the diaphragm through the pleural fluid. That means when you expand the chest wall, the lungs are compliant. They must follow. That's what compliant means. They must stretch and go with the chest wall. If we disrupt that pleural cavity, if we introduce air, that's like us with our suction cup, taking a little knife and prying off a little part of the suction cup away from the wall. The air now displaces the liquid from our suction cup, pops off. Everything will go its separate ways. The lungs will recoil like a deflated balloon. And the chest wall will recoil in the direction it wants to go. The chest wall wants to actually pop out. Did you know that? Your chest wall wants to, but it can't because it's tethered to the lungs. So when the lungs get to recoil when you exhale, your chest wall has to be compliant now. See, they take turns. Inhale, chest wall gets to recoil. It wins. Goes in the direction it wants to go. Lungs have to be compliant. When you exhale, chest wall has to be compliant. And I'll tell you a story to help you with this, about the chest wall wanting to pop out. When I worked at another community college, the first day of anatomy, they were to take a survey of the organ systems. And this survey entailed us going to, or entailed, I should say, not entitled, entailed us going to the animal room. The students would pick out a beautiful white rat. We'd have these large mouth jars with lids, and we would put cotton balls in the bottom, and we'd pour chloroform. And we would have to drop the rats into these jars, seal them up, and basically euthanize the rats. And that was the first day. It was highly entertaining for me for a few reasons, because I wouldn't warn the students about when they were putting the rat into the jar. Inevitably, they'd be like, ah. And it doesn't matter, male or female. Oh, ah. And they'd hold the rat dangling by its tail, and they'd start to lower it in the jar. And the thing is, what most people don't realize, animals that have whiskers, do you know why they have whiskers? So they are for sensory purposes. That's true. It's not for like, let me lick my lips. It's so if the animal crawls into a small space, if it bends the whiskers too much, that tells the animal's brain, I won't be able to get out. So, it helps them gauge the size of their head to the orifice they're trying to get into. So as these students are dangling the rats and they're trying to get them through this opening of the jar, inevitably the rat's whiskers would bend and the rat would do a total abdominal crunch. And that rat dangled by its tail, would suddenly do this abdominal crunch and latch onto the person's hands. And then the person would go, ah! And I'd have rats going everywhere. I learned to close the vivarium door so we didn't have to go chasing them out into the hallway. You make that mistake once. But then the not so funny part was when the rats were euthanized and we take them back to the lab room, they would put them on their dissecting trays and they would start to cut through the abdominal wall. And I wouldn't warn them, when they cut through the diaphragm and they broke the pleural cavity, they disrupted this water cohesive property and they introduced air. The chest wall of the rat went one way and the lungs went the other way. And the rat's chest wall would go like this, which made everyone go, ah! All over again. And they would say, my rat is alive, it's breathing. I'm like, all of its blood is in the tray right now. No, it's not. And I'd have to do a quick, and let me tell you about the cohesive property. So the chest wall would go out this way and the lungs would. They both want to go their separate ways. Because of this watery environment, they're tethered to each other and they're fighting. They're constantly trying to pull away from each other. That's part of the reason why we have the vacuum, a negative pressure, which helps keep the lungs tethered to the chest wall. Plus we have lymphatic drainage, which also helps with that vacuum. You disrupt that negative pressure. If you make it positive pressure, we no longer have lungs and chest wall following each other. So the lungs they're gonna move with the chest wall. They are compliant when we inhale, but then the chest wall is compliant when we exhale. They have to take turns going the way they want to go. So, what muscles do we need for expiration? No muscle contraction. We merely relax the external intercostals and the diaphragm. What about forced expiration? We now need to have muscle contraction. We're going to recruit our abdominal muscles, our external oblique, our internal oblique, our rectus abdominis, our transversus abdominis, and we're also going to recruit muscles called the internal intercostals, which originate from a lower rib, insert on an upper rib, and when they contract, they depress down. All of this is going to decrease the lung volume, which means the air inside your lungs will now have a higher pressure, and now we get airflow out of your lungs. That's our exhale. So both the lung and chest wall, what should you know by now? They have elastic tissue. They both want to recoil.
First one.
I ran to pee so Oh, it's like, where are you going? Bathroom's that way. Does anybody else need to go pee? Right now I can pause. All right, go pee. Go. So you just watched a video from Three Kings and you saw the tension pneumothorax. An atelectasis is the fancy way of saying a collapsed lung, but a tension pneumothorax tells you two things. It's not only telling you what's causing the lung to collapse. It's not always air that can do that. But the tension part means that it's getting worse with every breath he's taking in. You see, the wound where that bullet entered matters, the placement. You heard me say that lungs have height. So it turns out that low entry wounds can lead to a tension pneumothorax. And without getting into more material than what you need, we do this in patho though, when the person tries to breathe in, they actually suck more air through the wound. And as that air comes in through the wound and they try to exhale, the fluid in the pleural cavity and the tissue acts like a flap and it covers. So with every breath in, they're sucking it more air into that pleural cavity, but then it gets trapped. That's why he was saying every 15 minutes the air pressure will build and he'll have to provide an escape valve, another way out of the pleural cavity. And the reason why it's so life-threatening is not just because that lung now can't ventilate, but as it keeps collapsing, it pushes on the heart and also can start pushing the heart over onto the other unaffected lung. So now you have two lungs that are having a problem inflating, and the compression on the heart can lead to cardiac dysrhythmias. So he used a decompression needle. The ideal scenario would be that you repair the wound, you suck out the air, seal the wound, and in fact, you're going to do a physio-X where a patient will have a pneumothorax, and you are going to have to do a before, during, and after snapshot in your data collection. The ideal thing is to, again, remove the air, seal the wound, restore that vacuum in the pleural cavity. So you heard me say that we need volume changes first to lead to pressure differences, and then we get flow. You also heard me say earlier that we don't need much of a pressure difference, 1 to 2 millimeters of mercury. Now the question is, pressure difference of what compared to what? There are 4 pressures that I need to tell you about tonight. One is called atmospheric pressure. Atmospheric pressure is the pressure of the air around you weighing on your shoulders, weighing on your body. We are at sea level approximately, and that means we have a column of air that is extending into the atmosphere. And this column of air that's about a meter in diameter around your person weighs on your shoulders at a pressure of 760 millimeters of mercury. That is considered to be 1 atmospheric pressure. Now, you might not think that you have all this weight on your shoulders, but it is there. And this pressure is one of the pressures we need to keep in mind when we're getting flow into and out of our lungs. And just to turn this into a little bit of a comic scenario, when the boys were little, and I was working nights when they were little, just like I am now, even though they're big, they would come in and wake me up in the morning. And they would have to wake me up because if I taught nights, I was not wanting to wake up early. And they would come in and sometimes they would wake me up. Mommy, can we have some breakfast? Will you make us pancakes? Will you make us some eggs and soldierman? Blah, 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 whatever they wanted. I'd be like, oh. And I'd lay there. I'd open one eye, camera 1. Yeah, they're both there. Camera 2, same visual. Yeah, they're both there. All right, got. Mommy, will you make breakfast? I can't. The air is so heavy. How did you two get out of bed? The air is so heavy. Don't you feel it? It's 700. I told this to my kids. It's 760 millimeters of mercury worth of pressure. How did you ever get up out of your bed? And both of them would flex for me. Mommy, we got big muscles, just like Daddy. We got big muscles. We can hold up the air. I'm like, I'm not that strong. I can't. Yes, you can, Mommy. And they'd pull me out. They'd pull me out of bed, and I'd flop to the floor. And I'd be like, oh, no, I can't. The air is too heavy. It's too heavy. I can't do it. I'm just begging for extra seconds of sleep. And they'd stand around me, and they'd be like this. Mommy, we got the air. We're holding it up for you. Okay, come on, Mommy. And I'd get up, and because they were only little, so I'd have to walk through the room and down the stairs. We get all the way downstairs, both of them by me like, can you make it, Mommy? We got the air. We got the air. You gotta make it fun, right? So we get downstairs in the kitchen. I'm still like this. I'm like, I can't reach the cooktop. I can't. How am I gonna cook? You gotta get the air held up higher. So they'd go. So Hayden'd be like, okay, Mac, hurry up, go get some chairs. And Hayden'd be like, hurry, Mac, hurry! Like, it's collapsing! He can't do it! Hurry, Mac! And Mac's pushing the chairs. And then they climb up and they'd be on their chair, holding it like this. And I'd be like, okay, you guys gotta stay like that while I cook. I've been cooking both of them. Are you strong enough yet, Mommy? Can we go watch SpongeBob? Like, not yet. I'm not dying. I'm not awake yet. Super fun. 760 millimeters of mercury. We're in the pressure. Weight on your shoulders. How did you get to class today? Hold it for you, Rhiannon. The pressure of air in your lungs is called your alveolar pressure. We need a difference between the air out here and the air in our lungs. We only need a pressure gradient of about 1 to 2 millimeters of mercury difference. So if it's 760 out here, all we need is to get it to drop down to 759, 758 in our lungs, and the air will flow in, about 500 milliliters. To get the air out, we need to have a volume change where our lungs now are in a smaller volume, have a smaller volume. The gases in our lungs, the alveolar pressure, are now hitting the surface of our lungs, right? The internal surface. More strikes, more pressure. And now the alveolar pressure is 1 to 2 millimeters of mercury higher than the air out here. So we have to raise it to 761, 762, and that same 500 milliliters comes back out. We don't really think of that as work. But what if I told you, could you imagine creating a pressure gradient 16 times higher just to get the same air in and out of your breath? In and out of your lungs for a single breath? What would that look like? What would you look like? Right now, you are creating 1 to 2 millimeters of mercury of pressure difference. If it's 16 times higher, you would have to create 16 to 32 millimeters of mercury worth of pressure difference to get the same air in and out of your lungs as you are right now. What would you look like? And think about how much energy you would be consuming just to get that same amount of 500 milliliters in and out of your lungs. So this slide highlights for you all the steps I've gone through for normal inspiration, what muscles contract and how they work to expand the thoracic cage and the lungs have to be compliant, versus how you relax those same muscles, diaphragm and external intercostals, to get a volume change again in the lungs. They get to recoil, they get smaller. The gases inside your lungs are now at a higher pressure because they're hitting the internal surface of your lungs and the air flows out. So I've already told you about atmospheric pressure, the air pressure around you, 760 millimeters of mercury. How many of you babysit? Now you've got a game, don't you? Can you make us lunch, Kate? I can't get off the couch. The view is on. I can't get off the couch. Or whatever you watch. Alveolar pressure is the amount of gas pressure inside your lungs. In between breaths, when you no longer get air flowing in or out, it's because you've reached equilibrium between these two pressures. It's only if you have a pressure gradient that you get flow. But there are two other pressures that we need to talk about: intrapleural pressure and transpulmonary pressure. Intrapleural pressure is the pressure in your pleural cavity. You heard me say earlier that this should be a vacuum. That means a negative pressure. It's a negative pressure because we have the lymphatic drainage, and we also have the lung and chest wall, as you heard me say, trying to separate away from each other. So that intrapleural pressure should always be negative under normal, healthy circumstances. In the video where you saw Mark Wahlberg have a collapsed lung, his intrapleural pressure was no longer negative. The air got inside that pleural cavity, and it quickly equilibrated to the outside atmospheric pressure, which made his lung collapse. Transpulmonary pressure is a simple subtraction equation. We subtract the intrapleural pressure from the alveolar pressure. Look carefully. Intrapleural pressure is always negative. So what happens if you take a negative of a negative? You get a positive. That means transpulmonary pressure should always be positive. But it doesn't stay the same positive number. It can actually get to be a bigger positive number. How can I get a bigger positive number? By making the intrapleural pressure even more negative. The transpulmonary pressure is your distending pressure. Think of a little person inside your lungs trying to push your lungs open from the inside. That's a lot like my balloon analogy where I said, everyone take a piece of the balloon and let's stretch it. Think of someone inside your lungs pushing your lungs open, creating the volume change, which is required before you have a pressure change, before you get flow. The bigger your distending pressure, the more easy it is to inflate your lung, to get a breath in. We want a good distending pressure. We want a good transpulmonary pressure. Again, it's the difference between your alveolar pressure and your intrapleural pressure. It's the difference between the pressure inside your lung versus immediately around your lung in the pleural cavity. Let's do all of them again. So here is your chest wall. You heard me say that your chest wall wants to recoil outward. Remember the rat story that I told you about? Your lungs want to recoil inward. Because those two forces are opposite each other, it helps to create a negative intrapleural pressure. That intrapleural pressure should always be negative. But as you begin to inhale, its negative number gets even bigger. So from -4 to -6, for example. FRC stands for functional residual capacity. Towards the end of this lecture, you're going to learn about different lung volumes and capacities, and I'll ask you to breathe with me. In the next 2 weeks, you're going to be doing a lab with the spirometers that you see on the back shelf. The blue spirometers are called static spirometers, and they will measure your volumes and capacities without any respect to time. The white one in the back, as I like to call her Old Betsy, that white one is our dynamic spirometer. It measures how much air you can blow out in a unit of time. How much air can you forcibly blow out in the first second of your exhale? You should be able to get 80% of your air out in the first second of exhale. If you cannot, then that is a diagnostic tool where we will now say you have an obstructive disorder. Firefighters, when they finish their training, they have to take spirometry tests to show that they can breathe through the equipment that they might have to use if they're going in to fight a fire. And many of them fail their dynamic spirometry. Many students who have boyfriends or girlfriends that are taking their firefighter tests, when they fail their spirometry, they end up coming to me saying, can we come to class? Can we come to lab? Hook them up. Can you coach them? Because the nurse or whoever is doing the respiratory therapist, who's ever doing the test, will coach you, but if you're not paying attention to the directions, you will most certainly fail. Then it shows on paper that you have a breathing disorder. Well, you can't be a firefighter if that is the issue. So they come and they practice here, and then frequently they pass the next time they go. When you actually do that lab, you do not have to do your own dynamic spirometry. It is not a comfortable thing to do. It is not comfortable. Imagine exhaling as much as you can, as hard as you can, for as long as you can. It kind of hurts after a while. It does. That's what I'm saying. It's not comfortable. And you need someone to coach you. It will be me yelling at you. Blow, blow, blow! Harder, harder, harder! Go, go, go! And you're beginning. And it's frustrating as all get out because you'll see the needle go down as you exhale, but as I'm going, blow, blow, blow! Harder, harder! You won't see the needle move at all. And it's because the harder you blow out, the more your lungs, your air passageways collapse and trap the air. The harder you try and exhale, the more you trap it. You're not getting any out. So how do we get 80% of our air out, Kara? It's magic. Now, I'm going to teach you how. But if you don't want to do that one, we do have tracings already available for you in your lab manual. One will be a healthy tracing and one will be a diseased state. So you can pick if you're diseased or not and use that tracing as if it's you, if you want to. But FRC, functional residual capacity, is the amount of air left over in your lungs at the end of a normal exhale. It represents a moment where your chest wall and your lungs are at equilibrium. They are fighting equally to oppose each other. Neither one is winning or losing. So it's equilibrium between the chest wall and the lungs. Atmospheric pressure, you already heard me say, it's a column of air that goes all the way up through our atmosphere. We are at sea level, so the atmospheric pressure is 760 millimeters of mercury, but if you were to go to K2 or Mount Everest, the higher you are up in altitude, the less air above you, and the atmospheric pressure would be lower. That means you're going to struggle to breathe more, to get the same amount of air coming in and out of your lungs. That is part of the reason why when people go to Mount Everest, some of them will use oxygen tanks to help them with that ventilation process, to change the atmospheric pressure that they're breathing in. It's also creating quite a litter problem on Mount Everest. We have a lot of dead bodies up there and a lot of empty oxygen tanks. Everyone just leaves them there. Who knew that we had all this litter problem? We do. Intraalveolar pressure is the amount of pressure inside your lungs, inside the alveoli. Again, when the alveoli are bigger, you have a lower pressure. When they're smaller, you get a higher pressure. If your atmospheric pressure is higher than your alveolar pressure, the air will flow in, shown here. If your alveolar pressure is higher than your atmospheric pressure, then the air will flow out. Those are the two pressures that we need to get air flowing in and out of our lungs. Intrapleural pressure is the negative pressure in the pleural space created by lymphatic drainage, but also from the fight between the chest wall and the lungs to recoil and go their own way. Under normal circumstances, this should always be negative, but it can become more negative as you start to breathe in. Transpulmonary pressure is the difference between your intrapleural pressure and alveolar pressure. Intrapleural pressure should always be negative, so if I take a negative of a negative, this turns into a positive pressure. This is a distending pressure, a pushing open of your lungs. The higher that number, the more compliant your lungs are and the easier it is to inflate them. Did she need another cup? So we talked about how we can introduce a separation between the pleural membranes, the parietal pleura, which is on the underside of the chest, on the superior side of the diaphragm, and the visceral pleura, which is tightly adherent to the surface of the lungs. Pneumothorax is when we introduce air into that pleural cavity. It can get there from a wound. It can also get there from the alveoli spontaneously rupturing and the air leaking into the pleural cavity from the alveoli themselves. We can also have blood entering the pleural cavity. Blood is not the same as pleural fluid, and it can also disrupt this cohesiveness in the pleural cavity. So we can get a spontaneous rupturing of tissue bleeding into that cavity, and that can cause a hemothorax. Kind of weird to think about, but have you heard of a condition called endometriosis? Okay. This is where the endometrium, the inner lining of the uterus, does not grow on the inside of the uterus of a woman. It grows on the outside of the uterus facing the peritoneal cavity. When the woman sheds her endometrium from her uterus, it can also shed from the outside if it's growing there abnormally. And the blood will pool in her peritoneal cavity and can actually compress on nerves in the pelvic bowl. This is very painful. Endometriosis is a very painful thing. Now, some women grow the endometrium in other places. It's weird. Can you imagine growing endometrium on the surface of your lungs? And when you have your period, ladies, and that endometrium sheds, it sheds from the surface of your lungs, collects in the pleural cavity, and that is another way to have a hemothorax. Could you imagine that? That's a very rare way of endometriosis presenting, but some women have this abnormal growth on the surface of their lung. Now, if PMS doesn't get you, I don't know what does. That would make me cranky. Let's see. When we have any sort of disruptance in that cohesive property, we should know by now the chest wall is going to recoil out and the lungs will recoil in. We no longer have the ability to have the lungs change their volume anymore. So we breathe through negative pressure breathing. We create a volume change first, leading to a negative alveolar pressure, and then the air flows into our lungs. CPR is not negative pressure breathing. CPR is positive pressure breathing, where you are creating a pressure first, forcing air into their lungs, which in turn creates a volume change. When you also use, when you're using the bag to ventilate someone, that's still positive pressure. I think of the gallows for a fireplace, like the old cartoons where they would stick that in the character's mouth and. But what about this woman who's in an iron lung? Is that positive or negative pressure breathing? Great guess. It is in fact negative. You don't see anything over her face forcing air into her lungs, do you? Okay, so what you can't see from the perspective of this picture, she's in this chamber, and over here on this side, this is a plastic membrane. And on the other side, on the outside, is a mechanical arm. And when the arm extends the membrane, that creates this chamber to be ever so slightly bigger in volume, which means the air pressure around her body, now in a bigger volume, the air pressure in that chamber goes down. And you can think of that as less pressure on her chest. The elephant sitting on her chest has been removed. So now her chest wall can expand easier, making her lungs to expand, be compliant, and now the air can flow into her lungs. When the mechanical arm moves in, This decreases the volume, increases the pressure of the gases in that chamber, much like an elephant now sitting on her chest. This allows her lungs to recoil, smaller volume of the lungs, higher alveolar pressure, and now the air flows out of her nostrils. So this is negative pressure breathing. Very soon you're going to be assessing your respiratory volumes and your respiratory cycles. A respiratory cycle is a breath in and a breath out, full cycle. When we want to know your total ventilation, we're going to multiply how much air you breathe in a full cycle and out. And we're going to multiply that by your respiratory rate. You have a different respiratory rate as you age. Children have a higher respiratory rate than adults. Fevers can also change your respiratory rate, and that's part of the reason why that's one of the first vitals we take on a patient is their respiratory rate. Have you ever noticed that when the nurse is taking your pulse, kind of seems like it takes too long? What is the problem? Why can't you find the pulse? And many times when they're just standing there with their hand on your hand, ever notice you get quiet? Why, isn't that the weirdest thing? Like whenever they start testing, you're like, gotta be quiet. And when they're doing that, many of them are using that time. They're no longer taking your pulse anymore, but they're watching their watch, and they're also seeing how many times you're ventilating as they're just standing there. And you think, okay. And they're watching your chest. That's what they're doing. You're going to multiply respiratory rate times your respiratory volume from the respiratory cycle. The thing is, the volume you breathe in and out does not necessarily represent the amount of air that can actually participate in gas exchange, and I'll explain. So total ventilation is your tidal volume. That's the amount of air you breathe in and breathe out. It's 500 in, 500 out on average. Respiratory rate. On average, it's about 10 breaths per minute-ish. Alveolar ventilation is now how much air that you breathe in and out actually gets to the areas where you can have gas exchange, down into the respiratory zone. So as you see this 500 milliliters that I'm about to breathe in, watch. Not all of this air gets down into my alveoli. Some of it is stuck in my nasopharynx, oropharynx, laryngopharynx, larynx, trachea, bronchioles. It's in areas that are the conducting zone. So I need to subtract that anatomical dead space. That's what those structures, the amount of air that they hold, that's what we call it, anatomical dead space. So out of that 500 milliliters I breathe in, about 350 get into the structures that can actually participate in gas exchange. So if I want to know my alveolar ventilation, I need to subtract my anatomical dead space volume from my tidal volume. Again, it's about 150 milliliters is your anatomical dead space volume. If I subtract that from a typical tidal volume of 500, I get 350. If I then multiply that by my respiratory rate, I now have a better idea of how well my alveoli are being ventilated, because that's where gas exchange occurs. There is more than just anatomical dead space. There's also something called physiologic dead space. And this is where we don't have ventilation perfusion matching. That is going to take me some time to teach you about. And it will be our last lecture where I tell you about this issue between ventilation and perfusion matching and how your lung tissues participate in local control to try and get the best match possible. Because let's think about this. In order for us to actually get gas exchange, don't we need blood to come pick up the oxygen? Yeah, that's one of the ways, that's how we transport our oxygen, is somehow in the blood. So what is our typical cardiac output? 5 liters per minute. Well, what's a typical ventilation rate? You heard me say 500 milliliters. That's our tidal volume. Times respiratory rate, what's the average-ish? 10 to 12 for an adult, higher for kids. So if I take 10 times 500, what do I get? That's right, 5,000. 10 times 500 is 5,000 milliliters per minute. 5,000 milliliters is the same as saying 5 liters per minute. Coincidence? The amount of blood flow is equal to the amount of lung flow, airflow. They should be matched. You need the blood to pick up the air that you are ventilating. So your lung tissues are actually going to do quite a bit of work trying to make that ventilation perfusion matching as close as possible. It's very important. If we do not have that match, we're going to talk about physiologic dead space. We're going to talk about areas of the lung where the alveoli are well ventilated, but you're not getting the blood there to pick up the oxygen. And that depends on where you are. Upper regions, we have this physiologic dead space. Well ventilated, but the blood doesn't get there. I gotta teach you why and how your lungs can correct for that. So in a lab, not tonight because you're playing with your pee, but in your lab one day, you're going to assess your own ventilation rate. You're going to calculate your alveolar ventilation. Here again is a reminder on how to do that. And we're going to answer questions about what it would be like if you had a breathing problem. And it depends on which breathing problem you have. Obstructive versus restrictive. And on Thursday, you'll start to learn about those disease states. These are important terms. These are the terms of the discipline, as we like to say in teacher speak. These are terms you will likely hear me speak of, talk about as we move on for our last few lectures. Hyperpnea means you have an increased ventilation rate to match your increased metabolic demands. When would that happen? When you're exercising, of course. That's hyperpnea. So next time you're on the treadmill and you start breathing harder and you're working out harder, say, I have hyperpnea. Watch me. Hypoventilation versus hyperventilation. Well, let's look at hyperventilation versus hyperpnea. Hyperventilation, the ventilation you are doing, the breathing, is more than your metabolic needs. What would that look like? I don't need to breathe this hard. Correct? Everyone with me, try out for a porn. Next time you're watching a porn, go, she is hyperventilating. And tell me, try that. Inflate right now. Inflate your favorite inflatable toy. Tyler, don't tell me what that is. Just inflate your favorite toy.
Just start going.
Have you ever been inflating something and you go, whoa? Did you get lightheaded? Well, next week in lab, you're going to learn why. And in that quick amount of time, you are causing drastic changes in your blood pH. And in that amount of time, the reason why you're getting Fruit Loopy and dizzy is because the pH change in your blood is affecting your neuronal physiology. And that's why you're feeling faint and like, whoa. That should impress upon you how quickly pH changes can affect neuronal physiology. And whether it's acidosis or alkalosis, the person's neuronal physiology is not quite right. People with acid-base imbalances, and look at Christine because she will confirm this, if they have an acid-base imbalance in their body, they're probably not the most logical person. And you need to be patient with them when that happens to them. Am I right? Although most of your patients are not conscious. Most of them are like, oh, passed out. But they're not quite right in the head. Think of you feeling that way after hyperventilating. all the time. How logical would you be? Should you be driving a car? Probably not. Hypoventilation. What does that look like? Ready? I am not ventilating as much as I should for my metabolic needs. I have decreased ventilation. Mommy, will you buy me a snack? Mommy, look, can we have Lucky Charms? I need Lucky. Kids lose their mind going down the cereal aisle, don't they? Do you remember that? I need it. It's got a toy. No, put that back. Just leave them. Just leave them. Walk away. They might pass out. That's fine. As soon as they pass out, assuming they don't hit their head too hard, they will start breathing again. They will. They will. That's the reason why you drown. You'll hold your breath as you're sinking underwater. Eventually you will pass out and you will start breathing again underwater. And that is when you start sucking in air. That's hypoventilation. Tachypnea, rapid shallow breathing. What does that look like? Like Sigourney Weaver in Ghostbusters. When she had Zool. No one. When she was she was possessed by Zool, the dog. Remember one of the gatekeepers. No one appreciates my movie references. Apnea, temporary cessation of breathing. You've heard of sleep apnea, right? Well, we will talk about sleep and breathing in our last lecture. Sleep apnea, the person is breathing and then all of a sudden they stop. And usually before they stop breathing, they sound and look like this. And if you're their bed partner, you are not sleeping. And when they're not breathing. And that's when you're like, breathe! And now both of you are sleep deprived. Got to get that CPAP. We'll talk about what that is. Dyspnea, air hunger. You've all had dyspnea, but it was temporary. Have you ever been swimming? You went a little bit too deep. Wave came, tackled you. You're in the washing machine cycle. You're trying to figure out which way is up. You feel the air escaping you, and you got to get to the top, and it's a race, and it's a slight panic, and you just want to breathe. That's dyspnea. Now imagine that feeling all the time. That's terrifying. It's absolutely terrifying. Hypoxia, low oxygen content in tissues. That is not the same as hypoxemia. Hypoxemia is low oxygen content in the blood. Emia means in the blood. We can have a tissue be hypoxic, but the blood not have a problem with oxygen. We'll talk about what that means. Hypercapnia is a term for excessive CO2 in the blood. You will learn your normal values for CO2. Hypocapnia is decreased CO2 in the blood. Okay, that's the language of the discipline. You already heard me introduce the spirometry that you're going to do in the next couple of weeks. Static lung tests. We're going to breathe together in the next few slides. And those spirometers in the back, the blue ones, those are your static spirometers. When you work with those, you are the blower. You're a blower. You're going to blow. You're going to get blow jobs. You are not a sucker. There's no suck job, okay? So you're the blower. Dynamic lung tests. You're still the blower, not the sucker. If you suck on those spirometers, you will get a whole bunch of water in your lungs, and that's not okay. I don't want any of you drowning on land. And the dynamic spirometers are going to tell me how much you can exhale in the first second of your exhale. And again, you should get 80% out. All right, so breathe with me. Let's go over these volumes and capacities. Ready? Just breathe. Just breathe in. Okay, see, now look. I said breathe with me. Breathe normally. And all of you went. And when you do the spirometry in a few weeks or so, you all are going to go up there, and when you start thinking about your breathing, you're and you're going to get some crazy volumes and capacities, and when you do the math, it's not going to work out. You're going to get negative volumes. How do you get negative volumes? Can't have a negative volume. And it's because you all are going to be like, yeah, I breathe like this all the time. No, you don't. So, in science, you're not supposed to falsify your data. But for this lab, for the sake of getting the math right, if you get abnormal lung volumes and capacities, you have permission to fudge your breathing volumes and capacities to make the math work out right, because you can't help but think about your breathing when you're doing an exercise on breathing. In fact, respiratory therapists work quite hard to distract the patient so they're not thinking about their breathing with fun little games, and little breathing toys. They're like, try and breathe so that the ball hovers between these two. And you're like, it's a game. And meanwhile, they're taking their measurements on you. So breathe in and out naturally as best you can. 500 milliliters coming in and out of your lungs. Okay. Take a normal breath in. Stop. No, that was not normal. Now breathe in even more. As much as you can. Okay. That extra air you breathed in on top of a normal inhale is your inspiratory reserve. It's the amount of air after the normal inhale, the amount of air you can forcibly inhale after a normal inhale. You do not need to memorize these values. Okay, now take a normal breath out. Stop. Now breathe out even more. The amount of air you exhaled after a normal exhale is your expiratory reserve volume. Okay, breathe normally again. Breathe out. Stop. The amount of air left over in your lungs at the end of that normal exhale is called your functional residual capacity. You saw that on a slide earlier. That is when your chest wall and your lungs are at equilibrium. A capacity is 2 or more volumes added together. 2 or more volumes added together. When you exhaled as much as you could, there was still air left over in your lungs. That is called your residual volume. So residual volume plus your ERV gives you your functional residual capacity. Now I want you to exhale as much as you can. Breathe in as much as you can. Going from a maximum inhale to a maximum exhale, or as we did, maximum exhale to a maximum inhale, that's your vital capacity. Vital capacity is your IRV plus your TV plus your ERV added together. Let's see, what else? Total lung capacity. Breathe in as much as you can. Right now, you have as much air in your lungs as possible. That's your total lung capacity. Let's add up all the volumes. Breathe, breathe, breathe. It's your IRV, your TV, your ERV, and your RV. All of those added together. On your lab exam, you will be asked to match these descriptions to their terms. You do not need to memorize volumes. Why not, Kara? Because I thought it was enough that you had to memorize renal clearance values and equations. Thank you, Kara. You're welcome. Match these descriptions to their terms. Here's the funny thing about Lab 2 exam. I will have someone come up to me. My guess. And the prompt will say, the amount of air you can forcibly inhale after a normal inhale. And I will have someone come up to me going, are you talking about the amount of air I can inhale after a normal inhale? And I will say, yes, that's what it says, after a normal inhale. So you mean the amount of air I can inhale after a normal inhale? Yes, that's what it says, is after. So after, I don't know how else to say after. So you're saying after. Yes, after you've taken a normal, I don't know why. This should be the easiest sweep of points. And I take it straight from the slide. And I say this every semester. And I swear at this point, I think it's just a smartass who does it just to make it after. This is a tracing you will get when you do your dynamic spirometry, if you choose to do it. When we get to that lab, I will teach you how to calculate your forced expiratory volume in the first second. That's what FEV1 means. And how to calculate your forced vital capacity, going from a maximum inhale to a maximum exhale. You should get 80% of your air exhaled in that first second. If it's anything less than 80%, that is a diagnostic tool that says to us, you've got an obstructive disorder. Obstructive diseases, you will learn later this week, have very unique impacts on the dynamic and static spirometry. Their volumes and capacities change, and you will learn exactly how. Without having to memorize, you shouldn't have to memorize this. Once you practice your breathing and you're actually on the spirometer, you should be able to feel these things. If you say in your head, okay, now I have an obstructive disorder. I can't get my air out. Now I have a restrictive disorder. I can't get my air in. And you're going to play little games probably in your head. What would you look like if you had a restrictive disorder? And I'll give you the scenario. Let's say you have a huge anaconda snake coiled around you. Do you know how that snake kills you? It's a constrictor, which means every time you exhale, the snake tightens up even more, which means your next breath in becomes a problem. If you had to keep ventilating long enough to wait for help, for someone to uncoil the snake, whole bunch of people to uncoil it, how would you breathe? How would you breathe knowing if you exhaled too much, the snake would go? Wouldn't you try and expand your chest? And would you like this? Which is not ventilating, right? You're not getting air into and out of your lungs. What you're doing, you're panting like a dog. How would you look if you didn't have the anaconda, but you wanted to expand yourself? Have you ever walked around like this, arms over your head, trying to expand yourself? If I see that on a soccer field, I look at that kid and I'm like, yeah, we've got a restrictive disorder going on right now. My neighbor across the street who died of pulmonary fibrosis, restrictive disorder, washing her hair, took her breath away. She'd come out of her house feeling claustrophobic. She'd come out, arms over her head, trying to get that air in. horrible way to ventilate like that with every breath. Obstructive disease, trying to get the air out. How would you look? You'd be bent over, tripod, hands on your knees. You would use your abdominal muscles to push your viscera up as much as you could, doming your diaphragm as much as you could, and you might even purse your lips like this. And when you do that, watch. Longer air passageway, shorter. Longer, shorter. Longer, shorter. You are manipulating Poissonier's law. And I will show you how in the next few weeks. Okay. Have fun playing with your pee.